Hi, I'm Stacy Langford. I'm the Director of Emergency Services for Huntsville Hospital. That's the ER, the ED, whichever way you want to consider it. I do have a brief presentation that I would like to share with us. There we go. So that's me. So a little, just some interesting facts about the department. We have a total of 83 emergency department beds. That's including 16 observation unit beds. Observations are a little different. The inpatient units have an observation unit as well, but our 16 beds are dedicated to the ED. So how it functions is a patient is in the ED on a bed, they've been worked up, and now it's time to make a decision on if they're well enough to be discharged home or sick enough to be admitted to the hospital. And if they're in that in between, not really sure, we need to do more tests and treatments, we will send them down to our observation unit. We have a separate set of nurses and techs and case managers and physicians that work down there. And patients will remain in our ops unit for up to 3 days with the goal of keeping them out of the hospital and getting them back home. It's not every patient type of criteria. It will be patients that are, say they're asthmatic and they've had an hour-long breathing treatment and we need a second hour long, and instead of utilizing an ED bed, we will move them down to OBS, or if they have cellulitis and we can do antibiotic treatment over the next couple of days, they will be a candidate for that unit as well. The best patient population are the low risk chest pains. So they're here, EKG is normal, and they need a stress test and then follow up with the cardiologist so we can actually transition them back to our OBS unit and perform the stress test while they're here, and the cardiologists see them while they're here before they go home, or maybe they need to be admitted actually, which is really nice. It's a different pace back there. Most of the team, they like it. Patients love it in our OBS unit because it's quieter and less bells and whistles than are in the main ED, and they know there's a chance they're going to go home. We as a hospital, we are certified as a cardiac center. So we have a cath lab and cardiothoracic surgeons. We as a department, we're pretty competitive in our standard of care. And so our goal is if a patient arrives and they are having an acute heart attack, we want them upstairs in the cath lab in 30 minutes or less, 30. And the team here in the department, their record time is 4 minutes. That's just like 4, yeah. Arrival, EKG to the cath lab, they don't play. Same thing if a patient arrives either to our front desk in the department or by ambulance and they've got stroke symptoms, our goal is we call the stroke alert, and that notifies the neuro nurse practitioner, and we are a stroke center, so they will arrive to the ED. And our gold standard is from the arrival time to CAT scan is 20 minutes, 20 minutes or less, and the team, their record time is also 4. So that's, they like the numbers, but really what it really speaks to is that we can recognize an acute injury that quickly, and we're aggressive with getting the patient to where they need to be so we can give them the best chance at a good outcome. Of course, everyone's favorite, we are designated as a level 1 trauma center. There's only 3 for the state of Alabama, and that's UAB to the south of us, and way further south is USA. Get asked a lot of times, what's the difference between, UAB and Huntsville, Maine's level 1 trauma center. And the only difference, we do not have a burn center, and UAB has a trauma burn. So we do accept trauma patients here, and we will stabilize, and then we will transfer them either to UAB, or if UAB is at capacity in their trauma unit, then we can go to Erlanger in Chattanooga, or Vanderbilt in Nashville, because they have burn centers. But in the department, we have a total of 6 trauma bays. They are all set up the same. We have 2 different patient criteria. I get most of my questions about trauma, but there's a level 2 trauma, and that would be maybe a patient had, had a high-speed car accident and it rolled over and their blood pressure is stable, they're awake and alert talking to us, then that would be considered like a level 2 trauma patient, versus a patient, I'm so sorry, versus a patient that was maybe shot or stabbed, and they would be considered a level 1 trauma, especially if they're that critical. Let me show you a picture of what our actual trauma bay looks like. This is D44, and this is where the interest comes from. When I give a tour, they want to see, where do you take those level 1 trauma patients? So out of the 6 trauma rooms, this specific room, we call it Delta 44, it's in D-Pod. This is where the gunshot wounds, the stabbings, the really critical patients will come that have had a traumatic injury. Everything in the room is here that we need to take care of the patients. You'll see the supply carts on either side, and we train the nurses very thoroughly on who's doing what in the room. Everybody has their position of where they're going to stand. You can't see from the photos, but on the left side of the room, if we're facing the stretcher, there are 2 procedure carts that are there, and anything we need to do to take care of the patient from a procedure, if we need to put in an arterial line, a central line, if they have a pneumothorax and we need to do a chest tube, everything is there in the room. So we've got 1 cart that's for adults, and the other cart is for pediatrics. The pediatric ED is right up the block from us, and they will manage level 2 trauma patients and then just a general patient population of pediatrics. But here at the main ED, we manage the care of all level 1 pediatric trauma patients. So we have a supply cart just with their specific equipment and then baby sizes, and we train the nurses. We don't have the patient's age, then we will use a Broslow tape that is against the wall. It's kind of here in the front. It's not letting me show, but on the wall, and then that'll give us the kilograms for the patient, and we'll know what we need to do for treatment wise for them. Traumas go very quickly in the department. We're averaging from the time the patient arrives on the bed to being in the operating room is 17 minutes. So that's pretty fast. My nurses are always interested, and my techs, because our techs go through, we have what's called a red shirt trauma program. My techs that are interested in being on the trauma team are required to be in the department for 6 full months, and that gives us time to train them how to manage critical ED patient before we train them on trauma. And we will train them for a year before they work in this room by themselves. My nurses are required to be in the department for 2 full years. And again, that allows us to prepare them how to take care of a critical ED patient. And then we can get them exposure to some of the level 2 trauma patients that go to the trauma base next door. At year number 2, if they're interested in starting a trauma pathway, we will make sure they have PALS, Pediatric Advanced Life Support. And they'll take a Trauma 101 class and a test. And the test is not pass fail. It's just to see what's their baseline trauma knowledge that we're going to build on. And after that, we will train them for 1.5 years on every role that's in this specific room, D44. One role is the scribe. That's the very beginner level, and that nurse is in the back of the room, and that nurse documents what's happening in there, whether we're giving blood or we're starting an IV or another injury that the trauma surgeon may have noted. Then another role is the procedure nurse. And so those carts I mentioned earlier that have all the supplies that we need to take care of the patient, that nurse is the right hand of the trauma surgeon. And what we do is we anticipate what the patient's injuries will be based on the paramedics report. So if they call our supervisor, the paramedics, and they say, hey, we're 20 minutes from your facility. We've got a gentleman that's been in a high-speed rollover car accident, and his lung sounds are diminished on his left side, and his blood pressure is 80. Well, we go ahead and set up the chest tube then before they arrive. So when the trauma surgeon comes through the door, that procedure nurse is already ready and is just standing with the sterile package open, the sterile trocar. So that's the procedure nurse. And then on the patient's left side, if you picture the patient we're laying on this stretcher, that is our secondary nurse. And any interventions that need to occur for the patient is her response or his responsibility. And so we have a supply cart that is there. And things that nurse will be required to do is we use pretty large IVs. Most nursing students, they're like an 18 gauge. I put in an 18 and that was so big, and wow, I'm so excited. Yeah, so trauma patients get a 16 or a 14 gauge. So it's like, what? You're going to put that in somebody's arm? But it's to resuscitate them as quickly as we can. So 2 large bore IVs are required for our trauma patients. If it's a pediatric at 18, it's considered large bore for them. But that nurse has IVs in that cart that is accessible. If the patient is struggling to breathe and we need to put them on the ventilator, then we have rapid sequence intubation drugs, RSI drugs, and they're locked up in the cabinet. You see that in the picture. It's where that tape is kind of hanging off, and we have a key that the nurses know the code to get in there, and we give those. And before the patient goes to the operating room, we want to make sure we get antibiotics on board before they make that a first cut. So that nurse is also responsible, and antibiotics are also locked up in that cabinet. We make everything efficient, just nobody leave the room unless we're leaving with the patient. And then you can kind of see where the tape is in that little supply cart. It looks like an igloo cooler. That device is our rapid infuser. And so we have an infuser nurse, and that nurse just transfuses blood products to the patient. And it's like a pressure bag on steroids. So just one side of that level 1 infuser, we could put lactated ringers through in 1 minute. And a unit of blood transfuses through that device in 3 to 5 minutes. It has its own special tubing. It warms as it gets to the patient, so we don't get into the acidotic state, which coag, and the patient's going to bleed more, so everything's warm. If you are here in the department and you walk into 44 when it's empty, it's, wow, it's hot in here. You all just do this because it's the wintertime, though. It's like that 24/7 year round, so we can prevent the patient from getting hypothermic. So we rotate the nurses. No one is thrown to the wolves. If they're the procedure nurse or the secondary or the infuser, they will train with the red shirt who will be in the room with them. And we keep a spreadsheet that we're rotating through the roles. And after a year and a half, then they should be ready to interview with the trauma surgeons. I was like, oh, another interview. Yes. Very different. It will not be the sit down and discuss, and I'm interested in the ER and I want to be a flight nurse. It's not that at all. It's come in the room, and trauma surgeons show pictures of injuries, and they want to see the nurse set up for procedures, and then they will do a mock similar to what's done in nursing school, and they will give a mock trauma patient scenario and want to watch the nurse command that room from beginning to end. It's always an exciting day in the department. Everybody knows it's test up. It's like tryouts for the soccer team where we're like, did they make it? How did they do? I'm so nervous for them. And then the Reds get that status of red shirt trauma nurse or a red hat trauma tech. And the trauma surgeons buy us our first pair of red scrubs for the nurses, and for the techs, the red trauma bonnet. So it's very organized that's there. I get a lot of, how many trauma nurses do you have? We have 32 between days and nights that are red shirts. And those that are on the pathway are not included in that number. But at a minimum, I have to have 5 to run this room for the different roles. So we commit that to trauma services. There's a total of 5 board certified trauma surgeons. 1 is always here in this hospital, and the backup has a 15-minute response time. So we get asked that, what happens if you get 2? Then we call the backup in, and we run this as a disaster. If we needed this very room, we could put 3 stretchers in here if it's a mass casualty. And the ED is going to be the first receiving department. So each of our trauma bays can hold up to 3 patients apiece. When we do disaster drills, and we do them often, we prefer 2. We can move better with 2 stretchers in there plus equipment, but that is our trauma process. I get asked that all the time. So I just encourage my nurses, if this is something you're interested in, yay, and we're excited, but just know we've got to get you to the point. So it's 2 years. You don't come straight from nursing school into trauma. It's overwhelming, and we want to set nurses and techs up to be successful. So we wait those 2 years and train them. You'll manage a critical ED patient, if you're interested in ED, way longer than the 17-minute trauma. So it's really important to understand the why behind what we're doing for our patient care. A little bit about our team. We have 325 total team members. That's including our mid-level providers, nurse practitioner, PA, so we shorten that to be MLPs, our nurses, and our techs. We have a total of 35 board certified emergency physicians. So when they did their residency, they did it in the ED. So they're here. Out of the 35, there's about 10 physicians that rotate between being here at the main campus, but they also pick up shifts at the pediatric ED and also at Madison ED. So pretty well rounded because they see both adult and pediatric populations. Our physicians are at the desk with us often. And so it's a great opportunity for nurses and techs to, ask the physician, so, hey, so I was just wondering, why did you order that test? And okay, then if it comes back positive, what will you be thinking to do next? Which is great to do that and to question, because then we can put that in our tool belt. And I'm just so popular, I'm so sorry. We can put that in our tool belt and use that with the next patient type that comes in, and which is all to make the patient outcome better. So what do we offer as a department? We have opportunities to learn, because we see such a variety of patients. It's orthopedic injuries, neuro deficits, patients that are in DKA, patients that are septic, oncology patients. So it's ED, emergency nurses. We know a little bit about all of it. We don't just get, all we know is cardiology and that's it. It's like, bring it to us. We've got it. Our weak areas are pediatrics, since they are up the block from us, and we're so thankful for our peds ED team. Makes us a little nervous when mom or dad are not they're new to the community and they bring the little tyke here. We're like, what are they doing here? But we will triage them, and our ED physician will come out to triage, and then if the child is stable, then we'll transfer them to the peds ED. Some people think, oh, when they arrive, can't you just tell them from the front desk you're in the wrong place and you send them up the street? No, by MTALA laws, we are responsible for that patient once they are on our property. So we have to clear them first. Anything could happen between here and the peds ED, so we want to make sure they're safe and stable. There is opportunities to learn a little bit about all. Learning as far as what we do internally as a department is offer what are called ED critical care classes, because recognizing nursing school prepares us very well to pass boards. But it's a different challenge to come from nursing school straight into the ED. It's like, whoa. So I don't discourage new grads from starting in the ED. I get asked that a lot. Do you think I should maybe go to an inpatient unit first? If ED is your heart, then you should start in ED and let us grow you up and just continue to build on the skills. I do know some nurses, they prefer to get their med surge experience and then come. I just tell them it's a different mindset. You can't stay in the room as long as you may have on the inpatient unit. It's like, we gotta go, because there's more patients that are coming in. So the critical care classes that are mandatory for all of our nurses, this year I set the requirement at 6 by the end of the year, but we had to cancel a lot due to the pandemic. I plan to bring those back to 6, if not 8 classes next year. But the different topics that we teach will be a procedure class. Some of my nurses are not interested in trauma, and I'm totally fine with that. But I still want them to feel comfortable if the physician needs to set up for a central line or arterial line, or even a chest tube setup. We will have a very thin athletic gentleman that coughs really hard. He can have a spontaneous pneumo, and he will not be in our trauma pod. And so I want nurses to feel equally as comfortable setting up for those procedures. So we'll do a procedures class. We'll do a class on airway and talk about the difficult airway equipment that we keep in the department, and the RSI kit that we use, rapid sequence intubation. And when the physician wants to intubate, knowing and feeling comfortable with the paralytics and the sedatives that are in the kit and that we're going to give. And then we'll do a resuscitation class. And I've got the top drawer of the crash cart that's locked up here in my office. And so we'll just pull that out and go through in a controlled environment. So when you do open that crash cart, with purple box and the beige box, epi and atropine, and the red and white box, amiodarone, it's like, I don't know if I can give that. It's like, you can spike it, you can hang it, but at least we can build that comfort level so that when we're in the real room with the patient and the physicians, hey, let's push epi, then it's I'm comfortable, I've seen this, and I'm ready. We'll do a pacing class. We were trying to get a neuro drains class because we don't deal with the Becker drains a lot, but we need to be familiar with that. But those are just some. That's not all of the classes. Last month, what we offered was a class that was titled, "You're Getting an Unresponsive Patient to Your Room. What do you need to do to get set up?" And another class that we had was on sexual assault, what happens when a rape victim comes here, and from the ED to crisis support services. Two of my nurses are PRN with crisis support, and they are a sane nurse. So that's neat to have them teach. And then we did a class on three-way Foley bladder irrigation so that nurses can feel comfortable. I know we talked about that in nursing school, but now it's the real thing. And we're going to put those big bags through someone's bladder. Are you serious? We're going to do this. Like, yeah, and it's going to come clear and they're going to be better. So those opportunities to learn, there's opportunities for growth. I've already talked about trauma. That's a majority of what the pathway my nurses will take. The second pathway will be triage coordinator. And that's a unique and special role. That is the nurse who determines where every patient is going in this department, whether they come in by the ambulance, helicopter, they sign in out front, come through our lobby, they're being transferred from a outlying community ER to our ER. That there's one nurse that makes that decision. It's a tough role, but it's a leader role. And some of my nurses are really interested in that. And in my third category, they're just comfortable here in the department. They're like, I don't want trauma, I don't want triage. I'm just great and love it all. We do have, I need to add that, we do have a 4-bed behavioral health unit. We call it our preferred pod. And so that is, it's set up different from any other pod. To get in, it's badge access, and to exit out, it's the keypad, and the patients that are there do not know the code, so they're there. But it is our area for patients that are homicidal, suicidal. If they express that when they sign in out front, or maybe they're here with abdominal pain, and we do a suicide screen on all patients, and we determine then that they are high risk, then once they're clear from a medical standpoint, they will be taken to that 4-bed unit. Or they can come in by ambulance, and if they're homicidal or suicidal, they will be taken there. And what happens is we clear the patient first from a medical. We want to rule out, why are they feeling imbalanced? Let's get blood work. Maybe their blood sugar is off. Maybe their thyroid level is abnormal. And we need to get blood and a urine specimen because we want to check for drugs or alcohol. And a lot of times substance abuse goes hand in hand with mental illness, is how, our patients are coping. So we not surprised if we get an elevated level. But once we've ruled out there's nothing medical that we can tie into them feeling imbalanced, then our ED physicians will consult the psychiatric screeners, and they're actually here in the ED. Our sister campus, they use telescreening for Madison, and so they have to screen there and it goes in, but ours are actually here in person here at Maine. And the psychiatric screeners will actually go into the patient's room and assess them, and then they'll collaborate with the psychiatrist on the admission plan or the discharge plan with a safety plan if they are going home, as also communicating with the family member, a safety plan, what happens if they get home and they have a setback, things that we can do to work past this or to bring them back here. So I do have about 2 nurses on days and 2 on nights that are just superb with behavioral health population. And so they work there majority than anyone else in the department, as they really de-escalate well and make connections with those patients, which is so important. But that is an area in our department. And then there's an opportunity to make the immediate impact that's here. That's what we offer. We could see if you rush someone to the cath lab, and even in 30 minutes, and you get this card back. Or we've had the one gentleman, I keep sharing the story because it's just profound. And he was here, he was having a heart attack 2 months ago, and we rushed him up to the cath lab, and he's been discharged home, and he sent flowers back to the security greeter for the ED team. And he just said, just wanted to let you all know I'm walking my daughter down the aisle next weekend because you saved my life. And it's like, oh, that's what this place is about. It is. And you can get caught up in, well, there's so many patient types, and it's so fast, and it's so busy, and it's a process change, and now we've got COVID. But that's what we're here for, is to make that type of lasting impact. It is incredible, and it's almost immediate here in the department that we see that. That's what I love ED. If you can't tell, I think it's the best. But we have so many opportunities. If you're like, ED is not me, I'm nervous about that, then our cardiac units are fabulous. And also offer onboarding opportunities that are equally strong. I know the CCUs have a strong onboarding. There's orthopedics if you're interested. No, I think I want to deal with those that have orthopedic injuries. Then there are floors specific for that, or the med surge and family practice. Or if your heart is with oncology, then we have just a oncology unit, or we have a surgical step down. You're not really interested in being an STICU. I just want them when they come out of the unit. There's so many opportunities in nursing, one, but here in this organization two, to where you just have to find your niche. My best advice for my new nurses, what you start off in may not be what you'll be in for 20 years. And that's what's so great. You can change up from in nursing. Thought you want to be a L&D nurse or a neonatal, and lo and behold, you want to be in a cath lab, but it all works. It comes together. So I'm proud of what we do here and the opportunities that we have. I took that picture. I love that. When we first started with the COVID pandemic, and we had some children in the community, and they came, and all throughout the sidewalks of the hospital, they put different sayings. So that was what they put for us, this way to save lives. And I was like, yeah. You nailed it. And that what you're seeing is the ambulance entrance. If we turn the other way, it's 4 bays to where the trucks can bag in, and then they'll come through this first set of doors, and then the second set that's closed, they will come through those, and then they'll be in the department. And get asked a lot, what happens when they fill up those 4 bays? And they park on the street wherever they can, is wherever they fit in. We get calls from marketing. They're like, oh boy, you all are really busy. We see they're parked on the streets. Like, yeah, it's a Monday. What questions can I answer? Look for that more compassion. I know it seems weird. It's ED and it just needs to be hardcore. That's so not what I'm looking for. I'm looking for, if you can come with a genuine, I want to help patients. I want to help them get better. I want to learn so I can be a better provider. I will train you on the skill set, but I'm looking for those, that exactly what you said, the softer, being the patient advocate. And I know I've got to go talk to this physician. I'm a little nervous and I don't really know what's wrong with the patient, but I just don't feel right. And that I'm going to take that step, and I'm going to say, hey, I don't feel, something in my gut just tells me. And I know I'm not a 20-year nurse, but I just want, can we do something to get them admitted, to keep them longer? That's what I'm looking for. Be that advocate, just go that extra step. You're going to be nervous, get out of your comfort zone for the sake of the patient. And if you treat them the way you'd want to be treated, I can't stress that enough. And in interviews, I tell applicants, I'm like, I will define that. And I mean, being able to explain something to a patient as if they have no medical knowledge, that's the key. But you have to understand that yourself. And it's not, hey, we're going to get CPKs and troponin and you're going to go to the cath lab. I know none of that. It needs to be your heart can release this enzyme. And so that's why we did the blood work. And if so, then it shows us there's an injury and we need to call the heart doctor. I need that skill set, that I know it so well that I can explain it to you in, layman's language, and it will decrease your anxiety and it will build your trust, and you just relax knowing that we're going to take great care of you. That's what I need, that soft skill. So the department is a different feel. It's normal because the summer months. It's a great foundation to learn because there's more time. Hey, before we go in the patient's room, this is what we're thinking. This is what we're going to do. And versus graduating December, starting January, February, it's flu season and that's respiratory and it's, what is this place? And there's not that, let's talk about it before we go in the room. It's like, we got to go in there and save lives and let's talk about it at the end of the shift. It's a reverse. And so in the past, I've encouraged my nurses, I'm like, it's going to feel really stressful and you are going to doubt why you joined this team until about March or April, but stick with me and we will get you there. We're going to make sure you're safe and then it will settle down. And so this April, I didn't live up to that promise. It was like, whoa, there's a pandemic. So now the interview has changed to, I'm not sure what this April will look like. But the biggest thing is I want you to be safe, and I want you to take your time and know that even though we get you through orientation and then you're on your own, you're still going to feel like I'm not as strong as I was when I had my coach right here beside me, and know that we recognize that as well. And so be patient with yourself. Give yourself about 6 months for it to start really piecing together to where we allow our nurses to start protocol orders. So before the ED physicians come in the room, I mean, if someone slipped and we think their hip is dislocated, then yeah, our nurses order blood work, chest x-ray, all of that. And some will come to me and they're frustrated and they're like, the doctor got in there, why didn't I should have known. And it's like, give yourself time. It's been 2 months. And you will start to connect that, and then you will have that more of that critical thinking and autonomy, and that time management prioritization. Those are the critical thinking, time management prioritization. That's what we talk. And they're like, what can I do? I was like, it will come. I'm like, but the speed will get later. And so many nurses, they just want to be as fast as their coach was. And we will get there on speed, but your safety is the key. Keeping your patients safe and yourself safe as well during this pandemic. Like, don't rush, and recognizing that asking for help is a complete strength. It is not a weakness, and it's a hard mentality to get buy-in, because they're like, I'm an ED nurse. It's like, who recognizes weaknesses? So call for help. I just don't want to be a bother to anyone. It's like, you got to be that. The pods, we have what's called, the department's broken up into sections, pods. So the pod sizes range from, the smallest has 11 patient rooms, and the largest, being the OBS unit, has 16. The next one behind that would be pod D, has 14 beds. So each pod really functions like its own emergency department, because each pod has a physician. Each pod has its own set of nurses, its tech, its charge nurse. And so they get so siloed, and they're like, if they're in pod B, they're like, everybody in B is just overwhelmed. Everyone, it's like, pick up the phone, because pod EF might be fine. And they just don't get out of there like, oh, and I was like, yeah, I know they're down the hall, but they can help, like, call. Every time we bring on new team members, I send the email out to the team, and I'm like, hey, new team members. And the key thing I put in, remember what it was like to be new here. And you've got to take that and you've got to build. And I go to ER, we have our own, hospital does their own orientation, and then we do ER 101 just to hone in on things like, all right, this is a little different than what they do on the inpatient units. And I tell them, like, so when you hit the floor and you're like, oh man, I struggled with that, and you overcame it. When I send out, hey, here's our new team members, and when you're working alongside them, tell them, like, I really struggle with this, and this is what you're going to need to do. And I want them to do the same, and we keep going. But yeah, the mentorship is so important. I can't stress that enough to the team. And red shirt or not, I'm like, I'm going to come here as a patient one day, and I want to know that you all have got the skill set to take excellent care of me, and not, well, go get me the red, because I know they can. It shouldn't matter. So why don't we train everyone for that? And if you don't want trauma, we'll still get you the skills, and that way, if it's mass casualty, you can function. But okay, who's going to be the next one that we're going to grow up to do that exact same thing? Key. Said if they do struggle, tell them, come talk to me. Don't just leave yet. Let's talk through it, and to hear what their struggles are. I tell them, if you love eating, I just love it. My timing is off. The physicians, I just love it here though. And I'm like, oh, we can get you there. But if they're, what is this place? And I don't know. And I'm just trying to, when I go home, I'm so miserable and I'm crying. I'm like, oh, you don't like, if I just give it a little bit more time, do you think I like it? I was like, no, ED is straight love, hate. Majority of my nurses, as I talk to them, and I'm like, you really want a critical patient, but you want them for the duration, because you want to watch the holistic, you want to be more involved with the family, more time with them. Like you really want ICU, and go shadow. I'll pair you up and make the phone call, and put them in touch. I'll call Pam, and I'll say, hey, I'm going to send someone that they don't feel like it's a fit. I don't want them to be miserable here, but let's work with them. And I'll just, what did you like when you were in nursing school outside of the ED? Well, I always just thought it's ED. It's like something else just sparked your interest. And I mean, go shadow, and if you like it, then I'll release you. I won't keep you miserable. But if it's you're supposed to be here, sometimes you are an ED. You really, really are. You just don't believe in yourself, and we've got to help build that confidence. And over time, they're like, "Oh wow, I'm getting it. It clicks now." I would encourage nurses that are you're graduating in May. Do not wait until you've graduated before you apply. The orientation classes fill up very quickly, and they're limited in their capacity just based on social distancing. So if you're anticipating you're graduating in May, you should start applying in February 2021. So it's that early, and it's well, I don't have my license yet. You can get a temp license. We'll know you're coming. We will work with you in any department, but to go ahead and secure your space is key.